Hi, my name is Dr. James Crinsley. I'm Director of Critical Care at Stanford Hospital and Clinical Professor of Medicine at Columbia University College of Physicians and Surgeons. My article is called Glucose-Controlled Diabetes Status and Mortality in Critically Ill Patients, the Continuum from ICU Admission to Hospital Discharge, and it is set to appear in the Mayo Clinic Proceedings very soon. This is a two-center study with Tufts University. And at Tufts University, Dr. Stan Nazarway is Surgical Director of Critical Care, and he is the main collaborator with me on this manuscript. Hyperglycemia is very common in critically ill patients due to a number of reasons, and that has been recognized for a long time. But before 2001, when a landmark trial was published from Leuven, Belgium, demonstrating the positive effect of controlling hyperglycemia in critically ill patients, most ICU teams were not paying close attention to glucose. Since then, glucose control has become a very important topic in critical care medicine. Now, these studies have all been based in intensive care unit population. No one has ever examined what happens to ICU survivors when they get discharged to the regular medical floor. So that was the purpose of this study. We took a large cohort of ICU survivors and then looked at the relationship of glucose metrics, specifically hyperglycemia, hypoglycemia, and glucose variability, to mortality based on what happened during floor blood glucose control. Additionally, we stratified our data by diabetes status. So specifically, we compared patients with and without diabetes, because there is another strong trend in the literature that is looking at the differences between patients with and without diabetes. And specifically that patients with diabetes, especially those who have poor glucose control before they come into the hospital, reflected by a high hemoglobin A1C, might do better if they have higher targets than patients who are well controlled before they come in. For patients with diabetes, the appropriate blood glucose target in the ICU or on the floors is not clear, because there's no clear-cut relationship between mean blood glucose level and mortality at any range of blood glucose in the ICU or the floor for the entire group of diabetes patients. So this study is an observational study. It's not a randomized controlled trial. Therefore, we cannot prove causality. We can only consider these findings hypothesis generating. However, the strong hypothesis is that now we've demonstrated a strong association between glucose control metrics in ICU survivors on the floor. The next step would be to see if floor programs for glucose control, blood glucose control, can lead to better outcomes in a prospective randomized trial. There is a wealth of literature on glucose control in intensive care unit patients, but no study has tried to figure out what happens to ICU survivors when they get discharged to the regular medical floors. Specifically, is there any relationship between glucose control on the floors and ultimate survival? And that's what we tried to look at. This is a two-center study with Tufts, and it included a total of 6,400 patients in the ICU who had at least 5 blood glucose values, and then that turned into 4,400 patients on the floors who had at least 1 blood glucose value and survived the ICU. One of the interesting things about this manuscript as well is we corroborated differences between patients with and without diabetes. So for example, patients without diabetes, the blood glucose range of 80 to 140 milligrams per deciliter as a mean blood glucose level is strongly associated with survival, both in the ICU and on the floors. However, the correct blood glucose target, the optimal blood glucose target for patients with diabetes, remains uncertain, since there was no clear relationship between mean blood glucose level and mortality for patients with diabetes in the ICU or on the floor. So we really don't know yet what the correct blood glucose target should be for patients with diabetes. There are several published guidelines that advocate a blood glucose target of 140 to 180 milligrams per deciliter for all ICU patients. This is based on the results of the large NICE sugar trial published in 2009 in the New England Journal that demonstrated a slightly higher mortality in patients treated more intensively than that target. However, our investigation, as well as other recent literature, suggests that for patients without diabetes, a blood glucose target of 80 to 140 milligrams per deciliter is strongly associated with best prospects for survival. So, the takeaway message from this investigation is 1. Floor blood glucose control matters. Specifically, dysglycemia, hyper, hypo, and glucose variability are all independently associated with mortality in patients without diabetes, and hypoglycemia is independently associated with mortality in patients with diabetes during floor care. Second, there is a difference in glucose metrics and mortality when comparing patients with and without diabetes. These results call into question the guideline recommendations that a blood glucose level of 140 to 180 milligrams per deciliter is appropriate for all patients. The concept that patients should have blood glucose targets based on their personal characteristics fits very strongly with the theme of personalized medicine that has evolved over the last several years and seems to make a lot of sense to me. I believe that one size does not fit all.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.